So our patient of the week is a 45-year-old man who comes in with fatigue. He is assuming this is from just being out of shape. He has a new business. He has 2 kids under the age of 6. So he's just running a little bit ragged, and that's why he's tired. But he wants to come in and get some laboratory studies just to make sure there's nothing else going on. So you do a basic evaluation and get some lab studies. Hemoglobin is 15.1, MCV is around 89. He also has a ferritin, however, that's around 650. His liver enzymes are a little bit elevated in the AST, ALT. A1C is 5.9. Triglycerides are above 220, and his HDL is in the 30s. For more context, he doesn't smoke. He does drink about 2 to 3 beers most nights. No iron supplements, no family history of any iron overload disorders, and he has a BMI of 33. So now, based on our labs, we're kind of thinking, is this a hereditary condition? Because his ferritin is elevated. Is this a metabolic issue? He is drinking quite a bit most nights, so is this alcohol-related, or is this inflammatory? Typically, I'll post the answer towards the end of the week, but today being Friday, I'll just go ahead and give the workup and the answer right now. So one thing is ferritin is not just an iron marker, it's also an acute phase reactant, meaning it goes up with inflammation. So in our patient that's presented with fatigue and higher ferritin, it's important to also ask the question, is this because of a hereditary condition? Is this because of inflammation? So let's walk through this. His hemoglobin is normal, so there's no anemia. His MCV is normal, it's 89. So there's no iron deficiency pattern here. He does have mild AST, ALT elevation, so you're thinking liver involvement, right? Triglycerides are high, LDL is low, very consistent with a metabolic syndrome. And he also has prediabetes with an A1C of 5.9. Now this pattern is now screaming to you on the direction that you're going to go in for a patient. The diagnosis is, at this point, a metabolic dysfunction. So metabolic associated liver disease is what we're heading towards based on the lab studies we have. And there is some systemic inflammation based on the elevation of that ferritin level. Now the key steps here is, what do you do next, right? What are we going to do for our patient? We obviously are not going to jump to iron overload because that's not the problem in our patient here. But if you want to be absolutely clear, you can check a transferrin saturation. And if that's over 45%, then you know that this is not a inflammation, but more of a hemochromatosis. So our patient transferrin was less than 45%. Now, this can get a little bit tricky because it's how people usually will present with just something as simple as fatigue. But a ferritin of 600 looks scary. It's elevated, right? But in primary care, the most common cause is a metabolic disease, not iron overload. With hemochromatosis, you're seeing ferritins that are 800 and more. So when you're seeing a patient in the clinic and you're having sort of these numbers and thinking about evaluation, making sure that you're ruling out your differential based on the presentation that they're coming with. So based on our patient, how many of you were thinking this was an iron overload problem? How many were thinking this was hemochromatosis or maybe alcoholic liver disease and not a metabolic related issue?